Hi, everyone. Welcome to our webinar this afternoon. We're going to get started in just a moment. But if you'll take a minute to introduce yourself in the chat and let us know where you're from. All right, let's go ahead and get started. We have a lot of folks joining us today. Really exciting. I see folks from all over the US, and I'm really excited for y'all to be here and hear about this important topic we have today. So just a little bit of housekeeping before we get started. I encourage you to use the Q&A box at the bottom of your screen to ask questions throughout today's presentation. However, if you need to chat, you can use the chat as well. And just want to make sure everybody is able to participate as they would like. A little bit about us. My name is Lacey Hensley. I'm the director of the Institute for Coordinated Community Response. We are a program of the Conference on Crimes Against Women. We were created in 2018 as a training and technical assistance program whose mission is to work alongside rural communities to improve their collaborative systemic response to domestic violence. We provide monthly webinars, such as the one today, on-demand learning, are some of our e-courses on our website. We also have roll call trainings that are available for law enforcement or anyone that may be interested to view those for free as well. So thank you for being here today, and thank you for your dedication to improving your own community's domestic violence response. And you can learn more about our resources at our website, instituteccr.org. Now, on to today's presentation. I want to take a minute to introduce you to today's speaker, Rachel Ramirez. After working in the domestic violence movement for over a decade, Rachel created the Center on Partner-Inflicted Brain Injury to raise awareness and provide leadership on the unidentified and unaddressed public health crisis of brain injury caused by violence. In her 14 years at the Ohio Domestic Violence Network, Rachel has been supporting domestic violence programs and implementing trauma-informed approaches, as well as providing training, technical assistance, and creating resources for professionals working with domestic violence victims on a wide variety of topics. Rachel is a bilingual licensed independent social worker and registered advocate with senior standing in Ohio. So take it away, Rachel. I'm going to stop sharing and let you share.
Well, that's sure. Hi, everybody. Thanks so much for joining us. That sure sounds fancier than it actually is. I'm first of all, thank you so much for having me. I'm really excited to spend time with you all today. I think that I know that all of your time is really, really valuable, and there's a lot of other things that you could be doing. So I promise that I'll do whatever I can to make you feel like this was a good hour and a half spent. And I say the key to any good webinar is that it feels like it went by quickly. So again, my name is Rachel. We'll let you know that I'm from the Ohio Domestic Violence Network and am really, really excited to have the opportunity to talk to you about an issue that has become very, very near and dear to my heart. And we'll have some opportunities today as we spend time together to just I'll tell you a little bit about the story about how I got here. And thank you all so much also for sharing all of the places that you're from. I always miss, sometimes I feel like I spend a lot of time sitting in a room talking to myself, but I know that we wouldn't be able to be connected this way if it wasn't for the amazing gift of technology. So and like was said, if anybody has any comments or questions, please don't hesitate to either raise your hand, put them in the Q&A box, throw them in chat. We'll do the best we can to catch those. But I really think that this is an issue that we need to be talking about. And I'm hoping that what I do today, if I do my job today, that I make you want to learn more about this and about this topic of strangulation, traumatic brain injury, domestic violence, and how that all is related. So I'm going to actually give you just 1 second so I can pull up my slides and kind of get started. Here we go. And like I said, if anybody has any questions, comments, thoughts, please don't hesitate to put those in the chat, and we'll make sure to get to those. So as was said, I'm Rachel. I work for the statewide coalition on domestic violence in Ohio. Have been with ODVN 16 years. We have 76 member programs across the state that serve all 88 counties of Ohio. And my very first job in domestic violence was in a 103-bed domestic violence shelter. So shout out to all of you shelter people and domestic violence program people out here. I'm a advocate at heart, and still very, very much know how hard the work that it is that you do. Those of you who work in DV services, those of you who work in law enforcement or healthcare, or legal services, or all of the other ways in which domestic violence victims are touched. And I think what we're going to be doing kind of at the beginning of this is just talking a little bit about the journey for how we even got here, and how even after having spent a lot of time in this work, how I have become to really, really believe that this whole issue of brain injury, and where my passion for advocacy around really understanding brain injury as a critical component of domestic violence services came from, because this is not a conversation I would have been having with you even 7 or 8 years ago. It was not a part of my understanding of domestic violence. It was not a part of my framework. It was not a part of the work that I did with survivors. It was a big piece that I was missing, and I'm just really excited that all of you are interested in spending your time and thinking a little bit more about this. I did want to kind of acknowledge as we get started, as I know that we have 184 of us on here and counting. I've been doing this domestic violence work for a long time, and those of us who do this work know many of us feel very, very very, I don't know, lucky to have a job. Like, I can't imagine doing anything else. For many of us, this work is very, very personal, and we believe in it very, very deeply. And I go to bed grateful every night that I have an opportunity to continue to do my small piece and my small part. But I do want to just give, just kind of as we get the setting, even though I've worked in domestic violence for a long time, the whole issue of strangulation and head injuries and brain injuries, and really taking a moment to stop and think about what that really long-term impact can be on people it's terrible. It's terrible to experience being assaulted by somebody that you know and somebody that you love is terrifying. It's horrible. It's nasty to talk about. We all wish that these were things that never happened to anybody. But I do want to also acknowledge that many of us are here and do this work because we've had our own personal experiences with domestic violence, that we have been hurt by somebody who's supposed to love us, that we have had family or friends, maybe we grew up in a home that wasn't safe, or we had, colleagues, whatever it is that looked like. So I do just want to let you know, if you are somebody who has survived domestic violence or is experiencing domestic violence, you are by far the most important people in this movement, and we thank you for being here. But this information might impact you in a little bit of a different way. I don't have any real graphic, I don't have any graphic pictures, I don't have anything. We do have some stories of survivors, just some brief stories of them talking about their experiences of head trauma. But I just did, all of us need to, when we're dealing with this really hard stuff, use all of those self-care skills that we have. And please make sure you'll have my contact information. I miss being in person training. So I miss being able to stay and talk to people afterwards, but please don't hesitate to follow up with me if you need to, and do whatever you need to do to take care of yourself. Just to kind of get us started, I think that I want to kind of begin with the framework of domestic violence. And many of us who are here, who are in domestic violence or sexual violence, we could put, in this yellow circle, we could put human trafficking in there, and we could put crime victim in there. But we've spent a lot of time, and I mean, even from very, very early in my career with domestic violence, really talking about that intersection between violent crime, domestic violence, sexual violence, human trafficking, and trauma, and the overlap. And it's a really, really important context, because one of the things when we're talking about, when we start to introduce brain injury into this context, we're really thinking about what role does brain injury play? What role, when we think about the head trauma that people experience, this is happening in a very traumatic circumstance, in a very traumatic event, and a part of, a larger traumatic environment. So, I like to start this by thinking about those layers. And for those of you who have done trauma or trauma-informed care training, there's, kind of when we started talking about trauma and what is trauma, SAMHSA, the Substance Use and Mental Health Services Administration, has defined trauma, the 3 E's of trauma. There was, a lot of people talking about trauma-informed care, and we're recognizing trauma, but we didn't really have like a definition about, when we talk about trauma, what is it? What does that mean? But the 3 E's of trauma stand for event, experience, and effects. So an event, series of events or set of circumstances. It's more than just the event, as we know that we can have an event and people respond very differently. How do we experience that event? We experience that event by an individual as physically harmful or threatening. But I bet many of us have had events, series of events, or set of circumstances that we have experienced as physically harmful or threatening. But what it makes it traumatic is those, kind of putting these 3 things together with effects that has those lasting adverse effects on an individual's functioning and physical, emotional, social, or spiritual well-being. I really like this definition of trauma, because I think this really helps us understand kind of the subjective experience of trauma, where we all experience trauma differently. I always say, we all view the world, and we all filter today through our past lives and through our past experiences. I think a very simple example is, if anybody has ever been started a new job, our experiences with our previous jobs, with our previous supervisors, with our previous coworkers, we're absolutely going to bring that into our experience with our new job. But this is one of the reasons why we can have 2 people or several people that experience the same event and don't have the same impact, just because of all that variety and how, all of those things that contribute to that. So that's when we think about those 3 E's of trauma. And one of the things that we must know, you'll see these kind of slides as a part of these presentation. These are like the needs to know, is just really recognizing, just kind of like as a framework, is that the survivors we work with have experienced significant ongoing psychological trauma. And we'll talk about, and that's a space that many of us have spent a lot of time talking about, that psychological trauma. And then those 3 E's of trauma lead us into, SAMHSA also came up with the 4 R's of trauma-informed approaches. So many of us have been to training about, we want to be trauma-informed, and what does that mean, and what does that look like? And SAMHSA kind of helped us figure out, I think it's very easy to say, oh yeah, we're trauma-informed. But I don't know if you, like me, and that's why I spent many, many years working with our programs across the state, talking about, well, what does that look like in practice? what am I actually doing differently? How am I responding to this person in a different way? What am I seeing differently? What am I interpreting differently? How do our services look different? And the 4 R's of trauma talks about starting with realizing the widespread impact of trauma, just realizing what that impact is, and potential paths to recovery. Realizing that people do recover from trauma, that trauma does have an impact, but people are able to move on and move past that trauma, and get to the other side of that. Then we're recognizing the signs of trauma in survivors, staff, in our organizations. So it's not just the way in which trauma impacts. And I'm sorry, I use one of those words. Try to not just people when you do this work. We're never just. I don't know if you've ever done that where you're working with a survivor and you're like, so he just hit you. I remember I did that once the survivor was like, so what else was he supposed to do? So don't ever just people. That was just a little story. But we're recognizing that the signs and symptoms of trauma exist in survivors, exist in us, and exist in our organization. How do our organizations, policies and protocols and way we do things in our culture, how does that kind of reflect the work that we do in trauma? Then we respond by fully integrating that knowledge into trauma, into policies, procedures, and practices. And then thinking about resisting re-traumatization. Interestingly enough, a little side story, there were the 3 E's of trauma and the 3 E's of trauma-informed approaches. They actually added another R about this resisting re-traumatization, which is really, again, that recognition that re-traumatization is when somebody, through seeking help, often might feel like they're being re-traumatized again, that people are talking to them in a way that reminds them of their partner. They're being treated in a way that reminds them of their trauma. And I think it's really important to acknowledge that most re-traumatization is hardly ever intentional. People don't do that on purpose. There's not a lot of people who are in in this field of work who go out there to hurt people. They're trying to be really unhelpful and trying to do things that are going to be really damaging. No, it's done with the best of intentions, but it's really, really easy for this to happen. So that's why we have to intentionally and actively avoid that, really be thinking about it through that lens. But another must know, and I think when we're talking about that, is really just recognizing, and this is the area that I lived in this world of trauma and trauma-informed approaches for many, many years. One of the conversations we have not had so far is when we're talking about trauma-informed approaches is brain injury. It has not been a part of the trauma-informed conversation, not been a part of the framework that I used, not even been something that I had mentioned in the pretty extensive work that I did around that. And I'm sorry that, Lacey, I'm sorry that I didn't get my act together to get some poll questions in here. But I wonder if anybody just wanted to put in the chat, and I'm not asking for an exact percentage, but if anybody wants to put in the chat, how often do people you work with get hurt in the head, neck, or face, including strangulation? And I'm not asking for like 82.3% of people, but is it a lot? Danielle says 75%. Brandy says 50% of the time. Often 95%, 90%, 70% most of the time. Jessica says it often gets downplayed. Most of my clients, very often, we have, like, some people say 35%, some people say 45%, some people say 85%. I didn't mean to do that. I'm sorry. I'm playing around with things. Give me 1 minute. Close your eyes, everybody, because I didn't mean to do that. And people say, but one of the things that I think is so interesting about this whole issue about head trauma is whenever I ask this question, people say, well, a lot. And I know Mindy here, for example, Mindy says it's largely underreported. It's not something that, again, we've been asking these questions about. So I'm just going to move on to, I'm just going to take you over real quick. Give me 1 minute. And we're going to show this is about a 3-minute video. So we got this grant in Ohio to start to look at. The grant was around how do we create accessible services within DB programs. And it was really around, and we wrote it around mental health for anybody who works with mental health. We know that we can always do better with that. There's always things to learn, what it is that looks like. And we threw traumatic brain injury in there. And part of the reason why we put it in there, I don't know if any of you came to this webinar, you were like, TBI, I never really thought about it. Isn't that stuff that football players, that happens to football players? It was not something that we had ever, even though, most of you are saying, we know people are hurt in the head all the time, But like, I never really thought that head trauma could be a concussion. That's not something I thought about. And I'm going to play this very quick 3-minute video. We did some research. We partnered with Ohio State, partnered with some programs across our state, talked to some of our survivors who are accessing domestic violence services. And this is what we learned. And I do want to highlight Jennifer. One of the things Jennifer said in the chat is that once we start explicitly asking, the numbers go up exponentially. So I'm going to share the screen. And I'm going to take myself off camera for just a minute, and we're going to hear about what we learned in Ohio.
You hear people talk about evil in someone's eyes, like he looked through me like I wasn't even there. And I remember him putting his hands around my throat and like thinking like, I'm going to die.
When we think about the first picture of a domestic violence victim, the kind of classic iconic image of a battered woman is a woman with a black eye, right? Which one of the things that I realized now in the context of this work is she very well could have had a concussion in the context of that black eye, but it is something that none of us in the field have thought about.
And I don't remember much after that, but a nosy neighbor saved my life. Like somebody had heard all the stuff going on and knocked on the door, and that was the only reason I'm still alive.
And how we hadn't, it's one of those things you say it, you look at the data, we talk about brain injury and hits to the head, and it becomes very obvious very quickly. But even in my role at my organization as a statewide leader, having led a trauma-informed initiative across the state, trained in other states around the work that I was doing, never once had I mentioned brain injury. And how did we manage to miss that?
81% had reported being hit in the head. 50% or so many times that they couldn't remember. And 83% of the survivors working with the organizations reported that they had been choked or strangled so that their brains had been deprived of oxygen.
And the sad part for me is I'm an EMS educator. Like I teach trauma. That's like one of the things I love. And yet, even though as much as I know about trauma, I totally missed the strangulation part, the brain, and the effects that it's had on my body.
Many survivors who have been living with unmet need regarding brain injury intervention for a long time do end up developing comorbid issues like mental health issues and substance use issues, struggles with suicide. So unless we're identifying the underlying brain injury early, there can be other long-term health impacts for survivors of domestic violence who are not receiving the services that they need.
At one point, I attempted suicide. And so it was like, if they would have found this earlier, like, you know, my family has watched, and my friends and family have watched me, you know, try to end my own life and stuff. And it's like, that all could have been avoided had the right people had the right knowledge.
This has just kind of changed how we think about things and how we want to do things. And we're very, very hungry for helping us tackle this, because this really hasn't been tackled in this way before, and helping us from a practice level figure out what this needs to look like in the very complicated, very challenging work that domestic violence agencies do. All right, I am going to thank you all for seeing that. I'm going to do this really quickly, and I'm going to put there's the link, just for those of you to know in the chat. You can also Google domestic violence, the Ohio State University. Sorry, I can just do that. I'm an Ohio State alumni. And I know I had a question. Is there a Ohio report available in presentation form? I will talk about some of our website and what is kind of what we have done and what does that look like. We'll continue to talk through that. And we actually have some research articles about what we've learned through the research that we've done with Ohio State. I have a website I'll show you later at the end, but if you want to read some of the research, you can email me and I can send you PDFs of the articles. We're not allowed to just put them on the website because of copyright issues. But let me stop real quick and see if we have any oh, I said that Tess had a question. Will this be available in a video format that we can rewatch? I think so. Did we remember to record?
Yes, it's being recorded.
Perfect. All right. So I guess that answer is yes. If anybody else, we have any other questions, I'm just going to stop for a minute, and please also let me know if I need to slow down. I can get really excited about this and get to talking really fast. No other questions right at the moment. Okay. So we're going to go back to the presentation and come back here. And all right. So again, I think that what it was kind of the, that whole thing, like you knew it, but you didn't know it. But I remember when we first started looking at the data, we partnered with 5 domestic violence programs, and we went and talked to 49 survivors at the programs and asked that question, have you ever been hit or hurt in the head? And you will see 86% of people said yes. Which, and I don't know, many of you, in that, when I asked about that, many of you said 85-90% of people, but 49% of people said that they've been hit or hurt in the head too many times to count. Like they didn't even know a number. If we were to ask how many times, they were just like, I don't even know. And we just think about that, and it's just kind of the stuff that you've always known, but you've never really known, and just the incredible amount of head trauma that people have experienced. Then we asked those same people, have you ever been choked or strangled? 83% said yes. So a couple of things that we're learning, there's a lot of head trauma. There's a lot of coexisting strangulation where people are strangled and maybe assaulted in the head in the same incident. We also have people, again, 51% of people said that they were strangled or choked or strangled a few times. 20% said they don't even know how many times. So it's just, I mean, when you sit and take a look about it and you think about the amount of head trauma that survivors who are accessing domestic violence services experience, and just the fact that I was going to say, it was really just like most domestic violence survivors experience concussions and strangulation. Like, particularly for those of us who are providing domestic violence services. Now, when we look at the general population and all people who have experienced domestic violence, we don't have any good data about that yet. But people who are getting protection orders, people who are calling the police, people who are calling domestic violence hotlines, people who are coming in for domestic violence services, people who are disclosing domestic violence, particularly physical domestic violence to people, there's just a really, really high likelihood that they have experienced head trauma. And I think it's either, and people are either in one of two camps, and thinking about people who are seeking these types of services. They either have experienced head trauma or they're at really high risk for future head trauma. So this is one of the reasons why I think, that whole piece, I know somebody said earlier about how the numbers are exponential when we ask people about it. Yeah, once we started asking people, it was pretty much everyone. And I think even for people who are accessing our services who have not been physically assaulted or have not been hurt in the head, it's still important for them to have this information. We don't wait till people have sex to talk about sex, sex education and those kind of things. You don't wait till people have high blood pressure to talk about what can cause that. You know what I mean? So I think that just is something that we must acknowledge. And it's something that I did this work for years without ever really thinking about that. And the fact being that brain injury was really not on anybody's radar. It wasn't on. So I remember we had these groups and we were talking with advocates and professionals who worked at DV programs. And, we had this project and it was around mental health and it was around brain injury, which again, I think when we started this project, we're like, oh, there are these like 2 separate groups of people, and some people have mental health issues and some people have brain injuries. As you know, in domestic violence, it's all overlapping. It's all intersecting. And we can't, those are very, very false, like kind of, sometimes we put people in groups that aren't really, it's false groups because everything's overlapped. But one of the questions we were asking when we asked people, and you can think about this in your head, if you've ever worked with a survivor who was struggling with mental health, probably a lot of you have several different examples that come to your mind or people you remember. And I remember when we asked that question about mental health, there were all of these things that people were saying. When we asked about, tell me about an experience when you've worked with a survivor who had a brain injury, literally what we got in the groups and the conversations was this. It was silence. And people were like, I don't know if I've ever thought about it like that. But then as we were doing this groups, it would be later on and people would be like, oh yeah, remember that survivor who was unconscious and came to us from the hospital because she was assaulted? Like she was unconscious with her head injury and she was assaulted and we never took a framework of brain injury. And what that is, there never was. It just was something that people weren't thinking about. So that was just kind of this is another just fact of this issue is that most survivors are unaware. Now, if we had asked questions about survivors, we asked, have you ever been hit or hurt in the head? They said yes. If we asked them, have you ever had a concussion? They probably would have said no. If we asked, have you ever been diagnosed with a brain injury? They probably said no. And there's a ton of reasons we could talk about that, from lack of access to fear to safety issues to so many different reasons. But most survivors, I think that's the other thing that's really different about this, are unaware that brain injury could be impacting their lives. And we'll talk about this, kind of their lives on a daily basis. And also their ability to impact your service, to access services. So brain injury is making it more difficult for me to get services created and designed for domestic violence survivors. And it's not just domestic violence survivors, it's service systems are unaware that brain injury could be impacting a survivor's life, could be impacting their health, it could be impacting their job, it could be impacting their daily activities, could be impacting their overall well-being and their ability to access and successfully engage in services. So I think that that's something we'll talk about, what some of those signs and symptoms of brain injury are, what some of those things can look like in just a few minutes. But I think one of the things is when we saw this, we were like, holy moly, like these are all the reasons why people don't do well in our services. I know I have a thing that says Molly raised her hand. I don't know if you did that by accident, but if you did, Molly, I would like to give you some virtual candy and I will be quiet and see if you want to say something. And if you didn't, that's fine.
Hi, yes, can you hear me okay?
Yeah, I can hear you great. Thanks, Molly, for popping in.
Awesome. Yeah, sorry for interrupting, but this is just making me think. I work with incarcerated women and about just make me think about just the amount of women I work with who I believe have traumatic brain injuries, but that's not something I can obviously diagnose or even refer necessarily for a diagnosis. But also with repeated overdoses and how that impacts their brain health, alongside years of abuse and trauma to their brains. And so it's just making me kind of think of the overlap between overdose, brain health, and traumatic brain injuries from impact.
Thank you so much, Molly, for mentioning that. That's huge. And I will tell you that, when thinking about the whole multiple overdoses for people who have an overdose, often what happens when you have an overdose is you stop breathing, your brain doesn't get oxygen. Very similar. I don't want to say similar. It's not obviously not the same thing as being strangled, but from a kind of a brain perspective, when your brain doesn't get oxygen, that kills brain cells. And I think often what happens also with overdose, that can be very similar to strangulation. Often when people are overdosed, they do not seek medical care. Often we actually have a substance and mental health program of a colleague of mine. So if you're interested in more information about that, I can absolutely connect you. She's been thinking a lot about that connection, but there's no acknowledgement of that at all. And then we push people into services, we push people into treatment. We have all of these things that we need to do, that we're expecting people, requiring people to do, that require a lot of cognitive capacity, a lot of ability to do all that stuff. And then they don't do well. And then what do we think? We think, well, they don't care enough. They're not invested enough. They need to get their priorities straight. all of those different types of things. So I think that this is something that is really, really, and I mean, talking about like kind of the brain injury, we actually had a clemency project here in Ohio where we were working with 13 women who were incarcerated for very, 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 very long terms due to their partners, their abusive partners dying in an incident. But before we started this project, we consulted with someone. We're like, we're going to have somebody like just available in case, you know, we have any strangulation history. Like 12 of the 13 had really extensive strangulation histories. Many of them in the incident that their partner ended up dying, there was a head injury and head assault as a part of that incident. So thinking about that, and I think that and we'll talk a little bit more about how that framework really, really shifts how we think about things. I know that I'm looking at the question and answer. I know Dr. Amin, the Protecting Survivors from Traumatic Brain Injury Act, I'm going to answer this question really quickly, which was there was a Government Accountability Office report. One of the problems that we have is we don't really have any good data about how often this happens. Like I said, we did our research. We talked to 50 people in domestic violence programs. There's population-based data. There's all this other type of data we need. On all of our national data sets, we ask about if you're hit, if you're punched, if you're slapped, if you're kicked. We don't ask about the violence that was directed at your head, neck, and face. But actually the funding, I think that, and I'm going to try to not make this too complicated. We actually had several conversations with the Center for Disease Control, there was funding that was allocated as a part of an omnibus bill to collect some data on a couple of national population-based surveys called NISVIS, which is the National Intimate Partner in Sexual Violence Surveillance Survey. You can tell I'm not a doctor nor a public health person, but we are in conversations with the CDC specifically about how to collect some of that data, because one of the first things that we need to know, right, with any kind of problem like this is how big is it? Is it, do 10% of domestic violence survivors experience head trauma? Do 80% of domestic violence survivors experience head trauma? And that helps determine what type of resources that we need to address to this. But, I think that the other thing that I want to make sure for those of you who work in domestic violence, but also work in sexual violence, who work in human trafficking, who work with crime victims, the whole role of head injury has just been something that we have not paid attention to. And this is, domestic violence has its own unique flavor of this, but this is by far not something that is only domestic violence specific. When we look at strangulation that happens in sexual assault, or strangulation or other types of head injuries that happen as a part of human trafficking, it's off the charts. But again, and it's one of those things, but we've never kind of put two and two together to take this head injury to the way in which it could impact the brain. The other thing about that video that really sticks out to me is Paula, who is a good friend of mine. We've been to several different states to train. We're just I don't know if any of you were at NOVA. We were just at the NOVA conference. We did a keynote at NOVA. But Paula always says in that video, if the right person had the right knowledge, this all could have been avoided. Paula's brain injury was diagnosed 11 years after her near fatal strangulation. She, in that time, had attempted suicide several times, struggled with addiction, struggled with mental health, had 14 different medical and mental health diagnoses at certain points of time, was on 22 different medications, had her driving privileges revoked, had to declare medical bankruptcy. And even though she had head trauma or strangulation, oxygen deprivation documented in her medical chart, it was something nobody ever thought about. And one of the things she talks about when, her brain injury was originally discovered, after she was in a minor car accident, she rear-ended someone, couldn't remember rear-ending them, was hearing all of these noises. You can often, when you have a brain injury, be very sensitive to noise, to sound, just kind of because your brain is what kind of integrates all of that. She went to her doctor and asked her doctor to check her in the psychiatric ward because she thought she was going crazy. They did an MRI and there was petechiae in her brain, which is rare. We know that imaging is not a good tool for brain injury generally, but one of the things, the first thing that the doctor asked after that was like, have you had any bad car accidents? Like, it wasn't even a framework that abuse could be a cause of a brain injury, just something that we haven't thought about. So that's one of the reasons why I'm so excited all of you are here, is you are now the right people with the right knowledge. And we think about, and I think it was Molly who just made a comment who said it's never going to be her role to diagnose a brain injury. That's a medical professional's role. But imagine if Paula had called a hotline and somebody had said, when you're hit or hurt in the head or choked or strangled, that can cause a brain injury. And that can impact you in lots of different areas of your life. So we want to make sure that you're aware about it. Here's some information and some education about this. If you notice anything different or off or weird, maybe considering following up with your doctor and letting him know that you've been hit or hurt in the head. That could have really changed some of her trajectory and some of her outcomes. So I think the argument that I'm trying to make, and I don't know if you remember back from the beginning, we had this Venn diagram with 2 circles. This is a 3-legged stool, people. This whole issue of domestic violence and sexual violence and trauma and brain injury. Brain injury is a very, very significant piece of the puzzle, and a very, very significant piece that we have a unique opportunity to raise awareness on and address with people. So it isn't 11. I mean, every time I go out and do these trainings, every time I'm in person, every single time I talk to at least one, if not several advocates who have a history of head trauma and it's been years and years, and many of them are in new relationships. Many of them are in a much better space in their lives. Many of them have done a lot of the emotional healing, but they're still having problems. Like, they're having health problems. They're having problems with focus and concentration. They're having problems with work. So starting to really bring brain injury into the equation is something that's so important for all of us who work with victims of crime. And it is bringing that neurological framework. We've talked about trauma, we've talked about psychological frameworks, and we've talked about, kind of the mental health impact of domestic violence, the trauma-based impact of domestic violence. But domestic violence also has a neurological impact and can cause brain damage. When you're hit or hurt in the head, it can cause brain damage. And we're going to move into talking about how the brain works and what that looks like and all of those things that it can impact. But our brain has everything to do with what our body does. And so when it's hurt, it might not work as well. And that's something that there's so much, I think, when we think about survivors, particularly survivors who are struggling, there's so much shame around it. There's so many expectations that we often have as service systems, that people should just come in and they should be able to do this and that and this and that. And when they can't, or a lot of times we don't think about it as they can't, when they won't. And that's, if I look at me, I was like, oh, is this my next slide? I was hoping it was. When we think about people won't do things that they could, and if they wanted to enough, if they cared enough, if they were dedicated enough, if they were disciplined enough, if they prioritized it enough, that they would do it. It really, really changes our perspective when we think about, well, maybe people can't access these services the way that we've set them up. Caveat, big, huge caveat. We need to make sure thinking about this doesn't take us to a paternalistic place. We know that survivors are experts in their lives and that we're supporting empowerment and agency of survivors. But I always say, it's very, very different when you have a framework of maybe somebody's having problems accessing their services the way they're setting up versus they just don't care enough, or they don't want to, or they don't want to follow the rules. All of those kind of things just really change your perspective. And so, I mean, I think that these are all such important things to think about. So, and I think that this is when we see these kind of things, and I think that was kind of one of our big aha, we've had a lot of big aha moments, was when we see people who are confused, or all these things we say or we think about, they're unmotivated, they're disorganized, they just need to get it together, they're demanding, they don't care, they don't want it enough. People who don't learn from past errors, or they're non-compliant, they're not doing what we tell them to do, we should immediately be thinking about and ruling out a possible impact of brain injury. Those kind of things. And we're going to move in to just a minute to talking about the brain and how the brain works and how to understand kind of the different functions of our brain. But it really changes our perspective and our framework about when people are having a hard time with things. So this is actually a framework. I don't know if we have any occupational therapists on this webinar. If we do, I didn't know what occupational therapist was or did before this all started. I think occupational therapists are going to be some of our best allies and most helpful people to help us figure this out, and figure out what the response, what the solution, what some of the rehabilitation needs to look like. But occupational therapists work with people and what they're called occupations. Common, I know you would think that has to do with jobs, and of course, like I'm like, your occupation is your job, right? But occupations are actually, they call things that are called activities of daily living. So any kind of things that you think of, all those different activities of daily living, all the different things that you need to be able to do to go about your daily life. But occupational therapy, and what the occupational therapy does is they help people be able to successfully do these things. And if you think about all the different things in the categories about things you want or like to do, we have our hobbies, we have our passions, we have the things that we enjoy. One of the things occupational therapy also talks about, for those of you who work in DV services or shelter services or whatever that is, we spend a whole lot of time talking with survivors about things they need to do and things we expect them to do. Things that people want or like to do, that is what makes us human. If all of our lives were only things that we needed to do and other people wanted us to do, we would just be terribly, horribly depressed people all the time and wouldn't want to do anything. These are all very, very important parts of our lives. And there's a balance to these in order for us to be happy and healthy. But, things that we need to do, there are lots of things in life that we need to do. And then there are things that we're expected to do. We're expected to do by other people in our lives. We're expected to do by, by our family, by our friends, by our communities, expected to do in situations in our jobs, in different social circle, if we're on teams. I want you to think for just a minute, if anybody wants to put in the chat box, just what are some of those expectations, just expectations that we have in different people's systems. Elizabeth, thank you that it says non-complaint. It is supposed to say non-compliant, and you are the first person in however many times I've done this that has noticed that. So I will make that edit. But what are some of the things we expect people to do? Like, we expect people to show up on time. I mean, just think about like simple things like that, right? We expect people, when they make appointments, they keep them, and they show up in time. And when they show up in time and they fill out their paperwork the way that they're supposed to fill out their paperwork. What else do we expect people to do? If you work in DV shelter settings, we expect people to all get along. You look and dress or behave appropriately, call me back, call or text me back, manage their kids, expect them to clean their house. Any of you who work in shelters, get along with others, do their chores. It's just kind of some of those things that I will tell you, if anybody was to come and look at my house right now, I don't have any idea what my kid's doing. I don't know what my dog's doing. I don't know what the house looks like. Wear the right clothes that match the season, take advantage of help to share what their needs. There's a lot of expectations that we have. If you work in certain settings, we expect certain emotions. We expect people to behave in certain ways. Social conventions such as hello, how are you? We expect people to make eye contact, make a grocery list, all of these different kind of things. And we want to recognize that our amazing brain makes all this possible. Vanessa just said we remember some of the things that we've talked about or told them. So we have a meeting and we expect them. We talk about these things. You do them. You're going to remember them the next time. We expect them to be responsive to others in an appropriate manner. So those are all great examples. But I'm going to take you back to high school science for just a minute. Now, I am a social worker, so science was not my thing. So I'm going to try to do, if you're old enough to remember Cliff's Notes, anybody remember Cliff's Notes? Like when you had to read back before the internet and you could just Google about what Hamlet was really about when you had to read your Shakespeare in high school. We couldn't just do that back in the day. Imagine that. We had to read these little books. They were yellow, and if you ever read Shakespeare and didn't understand it at all, they had these little booklets that would use common language and do all of that. So I'm going to do that version of this. But we talk about brain cells are neurons. So these brain cells, and those brain cells connect and they form efficient pathways. And this is why I think we have so much focus on the age 0 to 3. Our brains are amazing, incredible organs. You think about a baby that's born. I remember I have 3 kids. When they were born, I remember one of my oldest baby, she was born a couple of weeks early, and she was having problems figuring out how to nurse and breathe at the same time. It was so funny. She couldn't figure it out. You think that she goes from that to by the age of 3, she is walking, she is talking, she has emotions, she can use language, she responds to people, she recognizes things. It's amazing. And that's, again, those neurons connect and they form those pathways. And what we say is neurons that wire together, that fire together, wire together. And that's how, and again, any of you ever learned a new language, learned a new skill, that's our brain, all of those neurons and forming those pathways. So we want to think about a healthy brain as like a city with 0 traffic jams, and we're able to do all of these different things. Some of you might be, I know none of you are doing this because you're wrapped and you're just sucked into this webinar and nobody's working on email. Nobody's doing anything else. Everybody just like they can't take a minute away from this. But many of us are able to do that. And someone can come in and ask you a question. You can still pay attention. You could be thinking about what you're doing later. That's our healthy brain. It doesn't have traffic jams. The brain also needs nutrients and protection. So when we talk about blood vessels, our brain gets oxygen through a couple of ways. We obviously get oxygen through our breathing, but we also get oxygen through our blood. And our blood pumps through our heart, brings oxygen up to our brain. It's like this cycle, this system. Leaves oxygen in the brain, goes back down to the heart, continues to pump blood. So that's how our brain gets oxygen. Our brain weighs about 2% of our body weight, uses about 20% of our body's oxygen. So that's why it's really, really, really important. That's when we think about strokes. It's so important that we have very, very quick response to stroke, because if our brain doesn't have oxygen for a very, very short period of time, it can be the difference with a minute or two, can be the difference between somebody having a problem that can rehabilitate versus a permanent disability. Also, because our body's smart, our brain is like a jello-like material. Think about it like gelatin-like material, kind of jiggly. It's packed very tightly inside of our skull, and it's protected by the skull. It's got some tissues and fluid to keep our heads packed, our brain, our most valuable organ, packed tightly within our head. And this is just when we look at the different functions of the brain. We have different lobes of the brain that are responsible for doing different things. And it's really, really important when we think about this to understand brain functions, as all of these kind of areas need to work well individually, but they also have to work together. So we think about, we have a lobe right here, our occipital lobe, which is responsible for our sight. So when we think about any kind of, if you've ever had, I don't know if any of you remember the old Looney Tunes where you have Wile E. Coyote and he runs into the cliff and he goes back and he's got stars around his head. Visual disturbances are a classic sign of a concussion, because what happens is our occipital lobe has had damage and we're not seeing things right. So we might not be seeing things clearly. Things might be blurry. We might be seeing stars or seeing spots or things like that. That's a classic sign, classic symptom of brain injury. But then we have these other parts of our brain. So I just want to think about, like, when you're walking around and you see someone that you recognize them. So you think about your occipital lobe. So use that first, you see them. But then, we have to, talk about memory. We have to remember, like, who that is, what that face is. We have this parietal lobe here that takes all of that information and it integrates that information into a cognition, into a thought. We're like, oh, that's George. So look at our temporal lobe. We have our long-term memory. We remember seeing him. Where do we have you ever been a place where, like, you see someone? I do CrossFit, so like I see people from the gym and we're all sweaty and we have our hair back and nobody wears makeup. And then have you ever been somewhere where you're like out in the street and you see someone and you recognize them, but you don't know where they're from? This is your brain trying to do all of that stuff, trying to figure out, like, I know them, I don't know them, they don't look right. How do I situate them? Then how often are you, like, an hour later, you're like, oh, that's Paula. That's who that was. Paula from the gym. So that's how our brain needs to kind of work together when we see that. We also have parts of our brain that are responsible for things like coordination, balance, even heart rate, swallowing and breathing. The temporal part of our brain is really responsible for language, hearing, and comprehension. So when we think about the difference, there's a difference between, being able to see that person, recognize who they are, know their name, or see a dog. You think about a little kid. I remember when my kids were little, they thought every four-legged animal was a dog because the dog was the first one. They called it a dog, but then they started to learn, oh, like, this one sounds different. This one's a little bit bigger. This one looks different. This one's in a different context. Now we have all of these different names. I remember seeing them. Now we have all of these different names for different things. But we have our temporal lobe, which, again, that long-term memory, our learning, our being able to learn things, and our emotions, kind of a lot of our emotional center is housed there. And then I know for those of us who have done a lot of work around trauma and trauma-informed approaches, our amygdala, our alarm system in our brain, is also housed in that part of our brain. And then we're going to talk about this other part of our brain, our frontal lobe, very, very important part of our brain. We'll talk about executive functions in just a minute, but this is the part of our brain that actually makes humans different than any other animals on this planet, because we have a frontal lobe. A lot of other animals do not have brains, this part of the brain that says developed. That helps us with things like executive functions and judgment, self-control, being able to control ourselves when we want something, and maybe we can't have it right now, or maybe it's not ours. Particularly thinking about our short-term memory and our personality. Our frontal lobe is what makes all of us individual people and unique, with our own separate thoughts and our own separate feelings and our own separate approaches. And our frontal lobe is one of the parts of our brain that it's not fully developed when we're born. Yeah, and I mean, when we talk about, and I know Elizabeth said other people have frontal lobes, but there are other people. I'm sorry, elephants are not people. So there are other, and again, I'm gonna do my caveat about, like, remember, all science isn't really my thing, but not developed in the same way that ours are developed. And I think particularly the short-term memory, working memory. So we'll talk about these frontal lobe. Is this part of it is like the sophistication of this frontal lobe. That's what I'm talking about. The sophistication of the frontal lobe is what helps us transfer information into memory. So being able to, for many of you, I don't know if you remember when COVID hit, maybe you never used Zoom before, you get on, nobody knows how to unmute themselves, nobody knows how to put their camera on. You might have been on Zoom the last hour, you might have not been on Zoom for a few months, but you can come back in and you're like, oh yeah, I kind of know how to use this. Some of you might use other platforms. I've never been on GoToWebinar before. I do a webinar on that, but like, I was like, okay, there's probably a mute button. There's probably like something, it's probably around here. That helps us, that information, it transfers us into memory and allows us to pull that back up, that working memory. It also, this is part of the brain that helps us put the brakes on impulses. So it really helps us do or not do something now because it's better for us in the long run. So how many times have we had, you get up in the morning, you know you should go to the gym, you don't want to go to the gym, but your brain helps you say like, okay, no, you don't really want to go to the gym, but you'll be really, really glad you did it. Remember how you feel after that. You have these goals you're working from. Or, you know, when we think about even the whole impulse control, how important that is for people who are in recovery, to be able to have, you know, kind of really want to drink, want to use, and be able to recognize and have those skills to be able to like, okay, I'm not going to do this now because even though I want it now, even though it'll make me feel good now, it's better for us in the long run if we don't do it. So our executive functioning, we talked about that a little bit, are these mental skills that include things we've talked about, working memory, that ability. You know, one of the things I talk about a lot with these trainings is I remember when I worked in shelter many, many years ago, we would have survivors that would consistently get lost. They would come back to shelters back in the day before cell phones. I mean, or there were cell phones were very kind of new, you know what I mean? And they've been in shelter for maybe days or weeks, and they'd consistently get lost coming back to shelter. Usually for a lot of us, our working memories, we go somewhere once, we go somewhere another time, you know, and then after a while, once you've gone to the same place lots of times, you're able to remember how to get there. You don't need to put it in your GPS. Flexible thinking, that being able to think about problems and approaches from different perspectives. You know, if something happens, we can shift, we can come up with a plan B. It's okay that things didn't go as they were planned. And even that self-control, this stuff is really essential for everyday tasks. And if you look at this list of things, I mean, I just don't know how many times have I even thought in my head, you know, working with a survivor who was like, what do they need to do? They need to get their priorities straight. But this helps with problem solving, time management, starting tasks, all this organizing and planning and multitasking. And I don't know if anybody wants to put in the chat box, if they were to look at this and say, what is the most important task? What do people need to be able to do in order to get your services? And I just want to let Elizabeth know you're coming with me to my next webinar to do the brain piece. Fingers help too. But sorry, I love jumping in the chat too. But what is most important? I know Sydney has her hand raised. Sydney, if you can take yourself off mute, we'd love to hear you. If you did that on purpose. I'm going to give Sydney just a minute or not. If you did that by accident, that's fine. They actually have this new Zoom thing. If you talk and you use your hands a lot, it actually thinks I'm raising my hand. I've done that before. All right, Sydney, if you decide you want to come off mute, please go ahead. Okay, Sydney, you're fine. But if anybody wants to, you know, Nikki says we need them to tell us what happened so we can help service them. They have to be able to tell us what happened, right? We need them to remember what it is. We need them to be able to communicate with that. I mean, I know when I look at this whole list in my shelter, we just kind of had an expectation that people would be able to do this. Like, you have to be able to manage your time because we have all these things that need to be done. We need you to get a job. We need you to find housing. You have to be able to start tasks. You have to be able to do multiple things at once. You're supposed to be with your kids 24 hours a day. You need to be able to watch them, and you need to be able to get your case plan done. You know, all of these things are just almost, we haven't even examined. Like, we just kind of assume and expect people to be able to do these things. And when our brain is healthy, we're able to do a lot of those things. And those things, again, we have the smooth wires, they all work together. But when the brain gets hurt, all that stuff, remember thinking about those different parts and those different lobes of our brain and the different responsibilities they have and how those brain lobes connect to each other, how they need to work together. It just all kind of throws things off. That's what happens when the brain gets hurt. And what we know about the frontal lobe right here, it's actually the most likely part of our brain to be impacted by head trauma. And a part of the reason was, remember our gelatin-like brain, it's kind of squishy. One of the things is behind our forehead, on the inside of our forehead, if you're thinking about that, there are bony ridges. So when our brain like rattles around in our head, our jello brain bangs up against these bony ridges and it causes damage. This part of our brain is also super sensitive to lack of oxygen. So if people have had lack of oxygen due to overdoses, due to strangulation, due to suffocation, due to any other type of violence that's made it hard to breathe, that makes, remember, all of these things, that's our brain's job. Our brain's job is to do things like our executive function, particularly our frontal lobe's job is to do all of these things, is to manage our time and to be self-aware and to have insight. You know, how many times have we worked with survivors and they're just kind of like wearing very inappropriate things or saying inappropriate, like, don't you have, like, where's your self-awareness? Like, that's, again, a brain function, right? So that makes all of these kind of things more difficult. And can create things like executive dysfunction when we think about executive functioning, which is our disrupted ability to manage thoughts, emotions, and actions. You know, brain injury can be, and again, remember, this is a big old hot mess. Embrace the mess. What I would say, you know, mental health can impact this. Substance use can impact this. Trauma can impact this. But some examples of executive dysfunction include things being like easily distractible, struggling to switch between tasks, focusing too much on just one thing. Have you ever worked with a survivor who's been like super labor focused on this thing, and you're like, there are all these other things that we need to be working on? Why do you care so much about those things? Again, that's a brain function. So, you know, I think that we want to remember when we see some of these things and when we see people having problems. One of the things that I think that the educational piece is so important is a lot of times people have a lot of shame, they have a lot of blame, they have a lot of guilt about they're not able to do things as well as they wanted to be able to do things, or maybe as well as they used to be able to do things. You know, and I've worked with survivors who have said things like, I used to be smart. I don't know what happened to me. And we also have domestic violence and these coercive dynamics, and people who have often told survivors, well, you're stupid. You're never going to be able to do anything on your own. Like, look at me. You're not going to be able to hold a job, and you're not going to be able to take care of your kids, and nobody else wants you. And then sometimes they leave relationships and they're not able to do those things, and they're hard. And they're like, well, maybe I am stupid, and maybe I am crazy, and maybe this is me. But, you know, and I think when we think about that, we also know that survivors are suffering from multiple traumatic events. So, and being assaulted in the head, being choked or strangled is, again, that is in and of itself is a trauma, is a traumatic experience. So you have these trauma responses that people are having. So our amygdala is on fire. Our flight, fight, or freeze hormones are out of whack. We might have had some neurological damage because our head has been slammed against the floor. And we have just not acknowledged the way in which brain injury or concussions could be playing a role in survivors and in their lives and in how they're able to get services, or if they're doing well within our services, or if they're not. I'm going to stop and see if I'm going to check real quick if anybody has any questions. Give you just a few seconds. And I don't see any in the chat box, but feel free to add if anybody has anything. We do want to acknowledge that it's almost impossible for me to make a list of all of the ways in which head injury looks like to survivors. And we talk about the multiple repetitive head injuries. I think that the other piece is we can see a range of different types of head injuries from, I don't like the term mild violence, because I don't think like any time anybody hurts you, that's a big deal. But we talk about maybe less severe versus more severe violence. I've worked with survivors who have been hit in the head with hammers. I've worked with survivors who have been smacked across the face every day. But there is this continuum of violence. But what happens is if people are hit or hurt in the head, if they were hit in the head with something, if somebody got pushed into something, if somebody was made to fall, even when someone is violently shaken, what can happen is if your body is jolted, so your brain is kind of rattling around in your skull, what that can often do is that kind of cut what it's called, it's kind of like when you think about whiplash injury, your brain can bang up against your skull here, then bang up back against your skull here. So that shaking, if somebody's had their hands put around their neck, had their head slammed against something, or done anything that made it hard to breathe, where sometimes it's choking or strangulation. We know strangulation is not a word that generally resonates with survivors. If you ask survivors if they've ever been strangled, a lot of times they'll say no. If you ask if anyone ever put their hands around their neck, they'll say yes. Has anybody ever done anything that made it hard to breathe? They'll say yes. Has anybody ever choked you out? They'll say yes. As kind of thinking about how we're talking about that stuff is really important. So, and I know Molly talks about the symptoms of trauma and PTSD can very, very much overlap. And we'll actually get to that in just a minute, talk a little bit more about that. But, I think that it's what we're talking about, trauma, PTSD, and brain injury. Like, it is trauma when you get a brain injury from someone. When somebody assaults you in a way that causes a brain injury, when it's an interpersonal assault from somebody you love, that is also traumatic. So I think that it's less about, the question is like, what percent of this person's memory issues is trauma versus, anxiety versus concussion? What does it look like when we're looking at all of these things together? So we really want to acknowledge that brain injury can change how survivors think, feel, and act. And I'm going to pull up one more quick video that's just a couple minutes long that you'll hear from my friend Paula again. As well as a couple of other survivors. This is not a pretty Ohio State video. This is Rachel on her iPhone with 3 people that I met personally, just talking about kind of what are some of the things that they noticed, kind of in hindsight about what it was like to live with an undiagnosed brain injury. And I want you just, as you listen to them talking about this, think about like how this impacts what kind of a reception this person might get. What would you think about somebody who was coming into your services or who was currently in your services, who was experiencing things like this? So this is just about 2.5 minutes long.
As I got further on in the relationship, I started noticing a lot of weird physical symptoms, but I kind of equated them just to be from the drama at home, from the drama and the trauma. I was working in the hospital as a nurse, and a patient would ask me to write down a phone number for them, and I would have to keep writing it on more than one sheet because my numbers would get really jagged. My hand was clumsy. I thought I was just exhausted from the trauma.
I just thought I was clumsy all the time, but my thing was just the fact of then when it was going on and after I got away from him, I was like, something's wrong with me. I'm not remembering to do things. My eyes twitching, I'm having these awful headaches and I'm stumbling on things. And I didn't know that was anything to have a brain injury.
I didn't want to deal with what happened, so I did a lot of binge drinking. So I was having nightmares and stuff, drinking to pass out, taking caffeine pills in the morning to function. In 2008, it started affecting my job, so I stopped drinking like I was. I was having flashbacks, I was having nightmares, and I wasn't able to hold conversations. A lot of mistakes. I was passing out. Like I would change position and I would just fall over.
My vision started to get a lot worse. People were noticing my eyes looked funny. My pupils were different sizes. I even went to my family doctor because I thought I had an eye infection, and he even kind of looked at my eyes funny, and then he just waved it off.
One particular one where I went to the hospital thinking that I was going to have a stroke. I couldn't, the left side of my face, it was numb. I couldn't walk right. And they had diagnosed me with a simple migraine, which I didn't even have a headache.
Everybody around me started to see symptoms that I was not aware of, especially aggressive, as it was explained to me.
I was yelling, like people would say certain things, get angry at them and yell at them, and sometimes I would just start bawling over something that should have been easy.
Right. So hearing from survivors about talking about those physical symptoms, talking about those emotional symptoms, talking about, sorry, I have to remember, I sometimes get, let me share my screen. I have to talk to myself. Shelly, thank you. I don't know if I have a great video. I don't know if I have a future in, what's it called, cinematography, but I mean, actually the two other survivors, Paula, obviously I know I see all the time, but two other survivors actually came to a session, one of the first sessions that I did on this topic, and just said so many things. I was like, we met in like a conference room after the end, and I was just like, I just need you to share this. I didn't ask them any questions. We're just sharing their story. But when we think about how it can change how people think, feel, and act, some of those emotional symptoms that they talked about, becoming equally frustrated. I know anger, we didn't deal with anger very well. We didn't, like, thinking about shelters, like, we didn't think people should be angry. We sure expected people, again, like if you were angry, you obviously had to be angry in an appropriate way. Talking about those mood fluctuations, what it is that looks like. It can look like people being non-compliant, or people saying or doing things without thinking, people who have troubles getting along with others. And this is when we saw this research and we're like, oh my gosh, brain injury looks like this. This is all of the reasons why people don't do well in our services. Even though they have brain injuries because somebody hurt them, and we're services that are set up for people who get hurt by their partners. It just was like, oh my gosh. But some of these things, people who are challenging other people, who don't follow directions. So again, that's what it looks like. Some survivors can, those cognitive symptoms, things like thinking, like memory, remembering to do things, taking longer to think or find words. So people who just, it takes a long time for them to talk, that comprehension, getting started on tasks, maintaining attention, even the challenges with risk assessment or judgment, that self-awareness. That was something we have a bunch of great brain injury collaborations here in Ohio. And we had somebody reach out to us. She actually had a brain injury in a bike accident, fell off her bike and had a concussion. And one of the things that we got, this sheet from the Brain Injury Association of Ohio, would encourage all of you to reach out to. Most of you have some kind of brain injury association or alliance that provides support to survivors, to people who have brain injuries, often not thought about from domestic violence, but people who have brain injuries from car accidents and falls and sports and all of that. And it was really around, brain injuries are even self-awareness. So how many times have we worked with a survivor who, and it was this whole fact sheet that was about how sometimes our judgment and our perception of how well we're doing things, that's a brain function. So how many times have we talked to survivors who have been like, oh, that's fine, not really concerned about things. We're like, this is pretty scary. Or, thinking that they're doing just fine at things that they might be having obvious problems in. Again, it's our brain's job to be able to accurately assess what we do well, what we're having challenges with, what we need help with. And when it's hurt, it doesn't do that as well. So this could look like getting easily distracted, difficulties concentrating. I worked with a therapist here in Ohio who was working with a survivor who had a brain injury. Luckily, the therapist had been trained around brain injury, really had a brain injury aware framework for her work. And, the survivor knew, but, she would say that the survivor would come into the therapy session, and 20 minutes into the session would start telling the same stories. And that she had already told, she didn't remember doing that. Talking about survivors who come and they would call to make appointments that they had already called to make and didn't have any idea. They're like, I don't know how I got that appointment, because they had called the day before. And how have we ever thought about that? So when we have people who are scatterbrained, who are not following through, who are losing their train of thought, that could be one of the signs of brain injury. And then, we heard Rebecca talk about those weird physical symptoms. So they might struggle with sensitivity to light or sound. And we've also talked about some of the overlap between trauma symptoms and brain injury symptoms. And I think that some of these physical symptoms can tend to lean more brain injury than trauma. There are people who can be triggered by certain lights. There are people who can be triggered by certain noises or colors, but like these lights hurt my eyes. Like I can't, or like they give me a headache, or like it's too loud here and I just feel like my head's going to explode because it's too loud. That tends to be something that's more neurological. Poor balance. I know people who are clumsy, who are tripping, who are running into everything. That is something that is not something that is traditionally trauma-based. So thinking about that, you're in a fog, that pain and discomfort, problems with sleep, problems with eyesight or hearing, you're tripping, bumping into furniture, all of those kind of things can be related to brain injury. And now when we talk about, no, we've talked about this a little bit earlier, and thank you for the time check. I'm on it. Though I would love to spend several more hours with you. Talk about possible symptoms. And again, there's no clear, hard, like fast fact on this. But when we talk about, there definitely is some overlap between PTSD symptoms and partner-inflicted brain injury symptoms. Though there could be things, again, that dizziness or balance, like psychological trauma doesn't tend to make us dizzy. Nausea, being kind of physically sick. Some of the seizures, kind of seizure activities being, those tend to be, and again, none of us are medical professionals. We're never going to be diagnosing brain injury. We see, but these are some of the things that could help us kind of, think through, tease these things out a little bit. What we are recognizing is when we're working with partner-inflicted brain injury, that is a traumatic experience. Like when you get a brain injury from somebody who assaults you, it's the PTSD and the partner-inflicted brain injury together. And how do we need to address that appropriately? How do we need to think about that appropriately when we're working with survivors? I'm gonna pause real quick for a couple of questions. I'm curious to see how you navigate the present medical need with TBI, but also trauma. Do you often do DV services and medical services like at the same time? That is really, really complicated. I know you had a follow-up question, Sadaya, and I'm sorry if I pronounced your name wrong. Run up issues regarding the client having barriers to receiving medical care and also not being able to keep the appointment due to DV and trauma, and also the TBI themselves. Yeah, this is all very, 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 I will tell you this whole system about how we're addressing brain injury and how we're addressing co-occurring trauma. That's one of the challenges, is a lot of our brain injury responses have really been set up for people with a couple of different most of our brain injury protocols actually have been built off of sports framework. And I would argue that I don't say there are a few things, but like playing a soccer game and being beat up by your partner are two very, very, very different things. And that's a part of when we think about this systems collaboration and these conversations that we need to have. I think what we very, very consistently see is hardly anybody who, kind of immediately when domestic violence and mental health and substance use is identified, people almost immediately go to a psychological place. You need a therapist. I mean, I have survivors who contact me from across the country, across the world, and many of them who are like, it's been 10 years and I've never thought about this, and I have lots of problems still, and I wonder if this could be connected. But, I have a survivor who reached out to me from Texas who was, she wrote briefs. That was her job. Her job is to write briefs. So she would read a lot of information, capture it, synthesize it, write a brief, was strangled, was unconscious for several minutes, and has having a very hard time grasping her reading. Like, she's like, I have to read really slow, and I have to read all of my pages a couple of times. That is not a trauma symptom, if you can think about that. Has been to many doctors. Doctors are keep referring her to psychiatrists. Kind of thinking about, there is very, very few, there are hardly any doctors that we've found that without bringing up brain injury or concussion as a possible. Again, we're not diagnosing. This is where some of the education and even the systems training is so important. It's not something that anybody will go to. It's just not something that has been acknowledged. But I think one of the ways that we can start to do that, and give me just 1 minute because I'm going to pull out of this real quick. And I know that we have about 10 minutes left. So I'm just going to want to move on to talking just briefly about, sorry, you have to give me 1 second because I can't talk and do this stuff all at the same time. kind of when thinking about how do we address head injuries and what does that look like within our services, and want to talk a little bit about what we've discovered here in Ohio. And we have built a framework, and this was in collaboration with our local programs, called CARE, has been evaluated by the Ohio State University as kind of an evidence-informed practice to really a health intervention, an intervention around health and domestic violence. Really bringing that awareness and knowledge on brain injury and how that has impacted service providers' ability to provide services that are more trauma-informed and support survivor empowerment. But it's really, and I wish I could say like there's this one perfect tool that we've created that everybody can use, and you just, you ask these 4 questions on the 3rd appointment and then everybody gets better. It's also really important to understand brain injuries and concussions. Concussions are just another term for a mild traumatic brain injury. Mild traumatic brain injury, concussion mean the same thing. They're really tricky because our brain is really complicated. So even when we see people in the best of circumstances, that have access to lots of medical care. I mean, just think about the struggles with concussions along the NFL, where those are people who are as healthy as they can possibly be with every single service available. There are no NFL players that have had to worry about transportation to get to their doctor's appointments. Every incentive to be able to get these brain injuries to heal as quickly as possible, these concussions to heal as quickly as possible. And our brain is just really complicated. So it's concussion is a clinical diagnosis. There isn't like a medicine that you get for it that fixes it. There's a lot of, managing concussions can be really complicated. But so this really is a toolbox that in a framework to help you raise awareness on brain injury caused by domestic violence. And CARE is an acronym, stands for connecting, acknowledging, responding, and evaluating. So we start by connecting with survivors by forming those relationships, really thinking about that, especially if this is a trauma-informed. We're talking about creating brain injury aware, trauma-informed services that are brain injury aware. So we start with that connection, and then we as service providers are really acknowledging that head trauma and mental health challenges and all of that stuff and psychological trauma are very common. We're providing information and education to survivors, and I will show you some of our educational tools in just a minute. And we're helping talk to survivors and identifying what are those physical, cognitive, and emotional consequences? How are the ways in which you personally are being impacted? And that, again, is one of the questions I always ask when I get these emails from people across the country, and they say, I wonder if brain injury could be playing a role. And again, we're not saying like, oh, we're wrong about the trauma stuff. We're saying like brain injury could be one of the pieces to the puzzle that has just not been addressed. We were not wrong about all this other stuff. There's just another layer to this, but it is really identifying, like, are you really having problems with focusing? Is that one of your issues? Is that you have a really hard time? You have a really hard time with memory, or you just like every time you get up and you're dizzy and it's hard to do anything. What we know is if people don't physically feel well, it's really hard. If you've ever not felt good, you are not in your best emotional space. You're not in your best cognitive space. When you're sick, you don't think well. When you're sick, your emotions are not under control. So thinking about, we also know that many domestic violence victims have a lot of unmet health needs. So I think that that's the other piece. It has really taken us to a place when thinking about DV, how do we need to be paying attention to survivors' health? There are survivors that have not had medical care for years and years and years, that might have uncontrolled diabetes, that haven't seen a dentist, that haven't had any OBGYN care, that also have needs related to brain injury, but it's identifying what is being impacted by your body. Are you having physical problems? Are you having cognitive problems? Are you having some of those emotional problems? What is it? And then we're going to respond by accommodating for those needs related, whatever those needs are. We're going to try to accommodate. And accommodate is really just providing services in a way that's most accessible. It's thinking about how are we providing services in a different way that better meets your needs. So if somebody's telling me that they really have problems with memory, we might need to write more things down. We might need to meet things more often. We might need to meet more often. We might need to put some reminders into somebody's phone. We might need to think if they have an appointment. We can't just tell them, all right, you have these 3 appointments next week and just expect them to all figure out. If people are having problems with orientation, with getting lost and things like that, we can't just give them a bus pass and then expect. And again, I think that when we don't have these conversations, then we expect people to do well. They expect to do well. They have a hard time. And then I feel like, what kind of stupid person can't ride the bus? Like, well, of course, if your brain has been hurt, a part of your brain's job is to be able to orient yourself and be able to get you. You have to figure out how to get on the bus and where to get on the bus and when do you get off and how do you transfer. And that's going to be harder for you. And it's not your fault. You're not stupid. There's nothing wrong with you. It's that you were hurt. I always say that nobody's ever, if you have ever hurt your leg or broken your leg, you are not upset with yourself because it's hard to walk. Like, of course you can't walk. You freaking broke your leg and nobody else was upset with you. Nobody's like, oh my gosh, look at that terrible person on crutches. I'm so over that person on crutches who's so slow. It's so annoying. No, you're like, of course that person's slow on crutches. Your leg. And guess what? We accommodate for them. That's why we have elevators. That's why we help people and we open up doors when people are on crutches. So we're really accommodating those needs. And we're also thinking about what are those effective, accessible referrals for people in advocacy. How do we need to do advocacy in a different way? What other kind of support? Do people need a referral to their primary care doctor? Do people need a referral with their primary care doctor with some information, helping them write down some information about their head trauma history? And then we're going to respond with these accommodations, these referrals, but then we're not done when we do that. Then we evaluate our accommodations and referrals. We evaluate how we're doing. We check back in regularly. We figure out, are these, if we're one of the accommodations, we're providing people with eye masks to help them sleep better. Is that actually helping them sleep better? And if they aren't, it's okay. We're not wrong. There's a lot of trial and error in this. We try something else. And that feedback loop is a part of effective service provision with survivors who have experienced this. So we want to make sure that we're providing education and information. I'm going to take you to our website to show you our tools that we have. We have service provision tools. I know somebody had briefly mentioned a tool called HELPS, which is kind of a brain injury screening tool. We also have a tool that we've developed in Ohio called CHATS. We want to be using care with survivors. I want to make sure that I think that screening, we want to make sure that we're asking some direct questions sometimes around head trauma and brain injury, but we're also making education and information available to people. But all of these tools are available. They're online, they're free, they're in English and Spanish, they're available for you to download. And these, we have found that this is what, we have learned with our work with Ohio State, that these really help you as service providers feel prepared and feel knowledgeable about brain injury and feel empowered to address that and empowered to accommodate for that. We also have this really, really exciting new, I had some on my desk. Oh, they're right here. I don't know if you can see them. They're little business cards. And if you can see these, they're little business cards. I am going to unblur my background so you guys can also see my room. But it just says on the front, being choked, strangled, or hurt in the head can cause a brain injury. So many people have never said that. And then on the back, it takes you to a QR code. It says, getting help can save your life. Learn more by scanning this code. And it takes people to a specific webpage that we've developed that is on our webpage specifically for survivors around brain injury. And I'm going to take you to that right now in our last couple of minutes together. And show you where that is. And I'm going to pull this up. All right. And this is our website, the Ohio Domestic Violence Network, odvn.org. If you go to our homepage, if anybody's in Ohio, our Domestic Violence Awareness Month event is on October 11th. You are more than invited to come to State House. We would love to have you. But if you go to our webpage, odvn.org, under our work, you'll see brain injury. You click on that right here. We have a lot of other cool stuff too. We have an e-learning academy, which we'll talk about some of the courses you have. And this is our webpage for our Center on Partner-Inflicted Brain Injury. Here's a recording to an On Point, an episode on NPR we were on about this. Here's the video that you saw earlier today. We have information about kind of our mission and our goals, but these are our brain injury materials. They're actually in the middle of a redesign, so in a couple of months, there will be some newly designed materials. But we have educational cards. We have a booklet that talks about brain injuries, and I'm going to click on this head injury education card right now just so you can see it real quick. It's just the front and back. It's like the size of, this is a bill, but it's like the size of this. This is the lab pay. But it says, has your head been hurt? And it's got information about, has your partner ever done these things? Are you having physical problems? Are you having trouble doing these things? Here are some things to do after a head injury. What are some of those danger signs and red flags? Information about if you're choked or strangled. We don't have any totally separate strangulation, and we don't have like a concussion brochure and a strangulation brochure because most survivors experience both of them. I did want to show you very quickly our chats tool, which is the tool, like I said, that has some direct questions about head injury. C is a question about choking and strangulation. One of the things that we saw missing on a lot of other brain injury screens, because choking and strangulation actually isn't that common outside of gender-based violence. Have you ever been hurt in the head, neck, or face? After you were hurt, this is altered consciousness. You feel dazed, confused, dizzy, or in a fog. Wondering if any of these things have happened recently. Has any above happened more than once? What are some of the troubles that you're having? We added some additional issues because we know, again, brain injury doesn't exist in a vacuum. In domestic violence, we have questions about suicide, alcohol, or drugs. Are you having any other health issues you want to share with us? Just general health. And then we actually have a guide for how to use that on the back. That is how you do it, what you do first, what you do next. So that is available again in English and Spanish. And right here is that webpage that I was telling you about. Those little QR codes right here take you to this webpage. So here's our webpage about head injuries, brain injuries, and strangulation. There's a quick video on what is a head injury written for survivors, what to do if you've recently been hurt, do you need medical care, and 10 things to know about domestic violence and brain injury. And I am going to stop my share. I'm going to throw up my contact information, and I'm going to thank everybody for their time today. I hope one day I will be able to maybe see you someday at a conference on Crimes Against Women. So everybody say on their evaluation they want an all-day session on brain injury by Rachel at the conference on Crimes Against Women. Not like I'm planning things, but you never know. I would say nobody ever said yes to a question that wasn't asked. Here's my contact.
I love it. Yes, we're definitely, you need to get your submission in. So, all right. Well, thank you so much, Rachel. So much great information. I learned a ton. If y'all want to grab Rachel's information really quickly, and then I have a couple of trainings to share with you as well. I'm going to go ahead and.
Yeah, you can go ahead. I'll put my chat. Very easy. Rachel@odvn.org, but I'll put it in the text box.
Okay, thank you so much. So we're excited to announce our third annual virtual rural conference on October 2nd and 3rd. This year, we're partnering with the Rural Justice Collaborative to highlight the specific needs of survivors experiencing substance use and intimate partner violence. So registration is open at the QR code there. And as Rachel mentioned, our Conference on Crimes Against Women 2024 RFPs are now open. They'll be open until the end of September. So if you want to grab your phone and take out that or scan that QR code, or you can go to our website, conferencecaw.org, to get more information. So thank you for joining us today. Rachel, thank you so much for your time. It looks like we may have just lots of folks saying thank you and great information. Look at all of that. Love that. So at the end of today's webinar, a survey will be populated in your browser. Please take a few moments to complete it in order to receive your certificate. The survey link will also be sent in a follow-up email. A recording of today's presentation will be available on our website, instituteccr.org, by the end of the week, and hope y'all all have a great afternoon. Thanks so much.
Everybody keep it real. Thanks for your time. Have a great rest of the day. I'll put my email address in here one more time. Bye, everybody.